Once again, Tim, let me take this opportunity to welcome all of us. Kindly, if you're not speaking, kindly keep your mic off, and your video also off. Let's give ourselves a few minutes for the other colleagues to join, then we begin. Let's propose to start at 10 minutes past 2. Ogutu, you can put up the agenda. Ogutu, kindly enlarge it a bit. There's a lot of background noise from your end. It's feasible, but you can enlarge it a bit, please. Yes, so I think we can we can start. Again, let me take this opportunity to welcome all of us into our HIS release webinar. My name is Franklin Songok from NASCOP. What has been shared on our screens is the agenda, so that's what we intend to cover today. Before we go on, I want to, because we may not be able to introduce ourselves, all of us, but kindly let's use the chat to introduce ourselves. Just indicate your name, your designation, and the county where you're coming from, or your organization. Right. So okay. So I want us to start, and I want to request a volunteer to lead us in a word of prayer before we begin. I know there are a few of us who have the mic. Diana, if you don't mind, can you pray for us, please?
Yes, I don't
Diana
mind.
To.
Let's pray. Mighty and everlasting King of glory, we come before you this afternoon. We thank you for the gift of life. We thank you for the gift of good health that you've given us. We don't take that for granted. Thank you for the responsibilities that you've given each and every one of us for the benefit of the people of Kenya. We pray that you may give us the wisdom as we have this meeting and give us the knowledge so that we can impact the lives positively. I pray this, believing and trusting in Jesus' name. Amen.
All right. Thank you very much, Diana, for leading us in a word of prayer. So I wanted to just quickly take you through the agenda. Then after that, I will welcome a few of our colleagues to make a few remarks before we begin. We really don't intend to take a lot of time on that because we have a lot to cover today. So so our intention is to basically just take you through some of the changes that we've made in KenyaEMR. Of course, this has been done. This has been made possible with the collaboration between Minister of Health and our HIS partners, led by Palladium through KenyaEMR's project. So we will do a bit of an introduction in terms of just welcoming a few guys to, a few leaders to open, to just give us a few remarks. Then we'll start with session one, where our colleagues from DHA will share with us some process of how to access devices for facility-wide EMR. And then we will delve into the presentations, and this session will be shared between four facilitators. That is Cosmas, Evans, Paul, and Mary Ann. So they'll take us through KenyaEMR feature enhancements. They'll also share with us the terminology compliance, the real-time facility case surveillance dashboards that have already been developed. They'll also be able to share with us a quick implementation highlights. Then we will go to the demo bit. This will be led by Eric Mudomi and Evans Nyaencha. Just basically looking at the enhancements and the new features. And then we will open it up for Q&A. So those three sessions will be covered back to back. Then we'll open it up for Q&A. Then Dr. Lily will take us through a call to action, just basically looking at just mentioning and emphasizing on the coordination that we require from you, the transition, the emphasizing on the reason why we need to transition from 2.x to 3.x, and just agree on what are the timelines. Then finally, that should be the end of our the end of our of our session today. So we intend to cover that within the 2 hours that is allocated. So before we go to the slide, to the presentations, I don't know that Dr. Jacob is in the call to just make a few remarks before we begin. Dr. Jacob.
George is on the call.
Oh, Jojo. Okay, Jojo Wiso, kindly go ahead.
Good afternoon, and Songo, confirm you can hear me.
Yes, we can hear you, George.
Okay, thank you. And good afternoon, colleagues, and welcome to this webinar. On behalf of Palladium Kenya HMIS, we are excited to be partnering with the Ministry of Health to ensure that digital health solutions meet the needs of the HIV program. We are aware and we acknowledge that this particular upgrade has taken a bit of time, and I'm excited that we are paying that technical debt today. As we go through the upgrades at the back of our minds, especially for colleagues who are technical partners to the Ministry of Health and the counties, we need to acknowledge that these are indeed specifically changing times, and our roles as technical partners will become our key focus, especially on how we support the Ministry of Health to sustain the investments we make for them. So as some sessions will focus on transition to 3.x, let us acknowledge that if we do not support those transitions, then we are being left behind, and some of these investments may not be able to be supported with the current implementations going on, especially on the need to move beyond the HIV clinic, where we have truly excelled. And as the HIV program continues to grow, our patients, of course, live longer and need other services. And our digital solutions should be able to be used for the patients, not just at the HIV clinic, but other clinics that they need health services. So welcome once again, and we acknowledge wonderful support from the U.S. government, and of course the great collaboration with the Ministry of Health as their technical partner to support this particular process. Thank you very much, and back to Songok.
Thank you. Thank you very much, George Owizo, for those for the remarks. Moving on, I don't know whether we have anyone from CDC, USAID, or DOD. Maybe you can start with CDC. I don't know that Dr. Sashi is in, or Daniel Mangi. If not, we can move to USAID. Apologies for the background noise. DOD, we'll give them an opportunity when they join us. Anyone from PCO? I don't know that Kate Mary is in the call, or anyone else from PCO. All right. At this point, then allow me to welcome Dixon. Dixon Kikwenai, who is the chair of Council of Cascos. And meanwhile, I'll also be looking out for Abdi Shale, who is the chair of the CHRIOs, or Kembua. I think I'd reached out to them. So maybe Dixon, you can go first.
Thank you so much, Tongok. Kindly confirm if I'm audible.
Yes, loud and clear. Dixon, go ahead.
Thank you. Good afternoon, colleagues. My name is Dixon Kigwenai, Casco for Narok. I also chair the Council of Casco. On behalf of my team, I know most of them are not on this call due to other engagements. Currently, there are a lot of competing activities, both nationally and at county level. But all in all, we are here representing counties, and we really appreciate, looking forward to learn more. And I really want to appreciate the opportunity and the continuous efforts to ensure that strategic information is very, very key to inform HIV programming in this country. And the efforts to update the digital platforms is quite key. Despite the turbulence that we are in right now as a country in terms of cutting of funds from government, I think as a country we need to look for means and strategies to ensure that we sustain effort.
Dixon, we lost your audio. I don't know that you're still. All right, it seems Dixon has challenges with network, is joining again. Meanwhile, I don't know, do we have any CHRIO in the house who can speak on behalf of the CHRIOs? Ruth Kiayu from Kirinyaga. I don't know whether you're on the call. All right. Okay. Fine. We'll give them an opportunity to speak probably before we close. At this point, allow me to welcome Dr. Lily, our SI lead, to just take us through the objectives, make a few remarks, take us through the objectives, and also welcome our colleagues from DHA. Dr. Lily, over to you.
Sonko, can you hear me?
Yes, Doc, I can hear you loud and clear.
Oh, sorry. The unmute button was saying that I'm not allowed to unmute, but I'm here. So thank you so much, Sonko and team, for convening this meeting. I think before we go through the objectives, I'd really want to just appreciate the. Am I still muted?
No, we can hear you, Doc.
Oh,
go ahead.
Sorry. So I was saying I'd really want to appreciate the healthcare workers that have joined this meeting. As you're aware, we have continuously adapted and being responsive to the emerging needs of the HIV programming, and that's why we have the upgrades frequently, so that we can make sure that the healthcare workers are able to utilize the system to provide better services for our clients. So I think now more than ever, especially in the current space that we find ourselves in around the funding cuts, it's important that we ensure that we are sensitizing healthcare workers just beyond the routine healthcare workers that offer HIV services, so that as we move towards the integration that we are envisioning in terms of being able to have any healthcare worker being able to interact with the HIV patients, we also make sure that our healthcare workers are also well sensitized around the how to use the system as well, so that we don't integrate and then lose the gains that we have sustained so far around our data systems. So therefore, I wish to just reiterate that this is going to be a meeting where we are going to be able to have at least around 4 objectives, and I'm going to just read as they are. So one is that we are going to get some highlights of the changes in the new upgrade, the version 19. And this is in regards to the terminology compliance. And then we're also going to have some demo at some point towards the end of the presentations on those enhancements that have been incorporated that are going to be in alignment with the earlier objective. And then, of course, we shall also be sharing with you some guidance around how you're going to do the upgrades. And then, of course, towards the end, then we need to all agree on how this shared responsibility is going to be implemented in terms of ensuring that we do the upgrades within a specific timeline, so that we can be able then to benefit from the upgrades that have been done. So with those remarks, allow me to hand it back to Songok, and then we shall continue to interact through the sessions. Thank you, and back to you, Songok.
Thank you so much, Dr. for your remarks and just taking us through the objectives. I'd requested that you invite one of our colleagues from DHA, but I think I can go ahead and do that. I know we're expecting Dr. Joyce, Momo, and Diana. I don't know who is in the call. Diana Kamar? Or Jeremiah Momo. I think I can see Jeremiah in the call. Diana Kamar, if you're in the call, or Jeremiah Mumo. I can't see all the participants. All right, fine. I think we will give them an opportunity to make their remarks as they join. Meanwhile, I know Diana was to go first from DHA. DHA is the Digital Health Authority, because they want to go first to share with us the process on how to acquire the devices that we'll be using, especially to support facility-wide, the rollout of facility-wide EMR. But meanwhile, I think as we wait for them, because of time, I want to usher in Cosmas. Cosmas will take us through the first part of the presentation. Cosmas, once you're done with your presentation, you can usher in Evans. Evans, once you're done, you can usher in Paul. Then Paul, once you're done, Mary Ann can close that session for us before we go to the demo. So over to you, Cosmas. We will allow Diana, Kamara, and Tim to make their presentation once they join. Cosmas, over to you.
Thank you, Sangok. Just confirm you can hear me.
Loud and clear. Go ahead.
All right, thank you. I think, again, just to welcome you all to this webinar. And I think as the previous speakers have said, we're really excited to really bring you some key changes that, of course, as users, you have asked us to do. And for that, of course, we've made some changes just to also to respond to your needs. So I'll just be really taking you through some of these changes. And this is to start with, of course, the terminology changes that we've done within the EMR. So if you could kindly just move to the slide 7, whoever is moving the slide. Thank you. Kindly to slide 7. Yeah, so I'll really just take us a very short time just talking through this, all the way to the new features, what we've done, what we are trying to achieve, of course, also to be able to, of course, be in tune with the theme of the country with when it comes to digital health and how we can, of course, make it sustainable in the long run within the facility. So if you can kindly move to slide number 7. So on we've had some bit of terminology compliance that we've done. And this is really much just to ensure that we've streamlined and we're compliant when it comes to biological categories, but also at the same time, we've also ensured that the terminology will not be able to affect what the current classifications are. But just to name a few, some of the things that have been, of course, affected by this will be the MOH 731 plus, and this will be reporting tools on HTS initial, retest, and KVP forms. You also have the KPIF. Again, also, this is one of the tools that has been affected by this. We have the SGBV registers. We have the HTS confirmation register, and of course, the DATIM tool that also has been affected by this. So as you can see on the far right, just to show some of the tools affected, this is the GBV forms and of course the HTS forms that I've mentioned previously. Next slide, please. We, again, of course, have been listening to our users and we've been interacting with you just to be able to, of course, provide some changes that you have felt that are really needed for your work to continue, but also to just make the EMR as intuitive as possible. And some of these changes are new features and, of course, improvements from bugs that have been collected. And I know my colleague Evans will talk about more of the bugs that have been fixed. But what I want to, of course, communicate here will be just more in terms of the module changes that we've done in terms of improvements and new features that you should be able to expect. We have, of course, the pharmacy dispensing app, and I'll get into more details in the next slide. But for now, I'll just mention in terms of improvements, what we've done is just to include, of course, the features that were in ADT to ensure that we have comprehensively covered that. We've also added some new features, and this is to really support the facility-wide implementation. Again, like I've said, this is towards, of course, gaining sustainability and in line with the Ministry of Health priorities. So we have, of course, the ability to add prescription, and you can be able to print it. You can also be able to bill the prescription at the dispensing point, and of course, any out of stock drugs you might not be able to dispense. Then we have stock management, and here we've just tried to make sure we have a well-defined operation. Before it was attached as just one, so we have a positive and negative adjustment. Of course, we've also added some operations in terms of ensuring that whatever operations that you do at pharmacy, you should only be able to see them at pharmacy. Whatever stock operations you do at main store, you should also only be able to see that at that point. Of course, some of the things also we've done is just to redesign the dashboard also for the stock operation, and we should be able to view information in full. I know some of them were truncated previously in those versions, but now you should be able to see this in full. On the new features, we've added the stock card and the bin card. This is another drugs transaction module, and you'll be able to see this information. On the care and treatment, we've added the missing child second line regimen, TLD. And also we've added the addition of the TAF-LD, and this is for the second line regimen for adults. Then for the clinical forms, of course, some changes I've done on GBV forms, HTS initial, retest, KVP forms, and special clinic forms. New things to expect when it comes to the clinical forms, we've added the infectious disease form. That is one of the examples, among other forms also that are available. On the patient chart, we've made a bit of changes to really collapse some features together. And this, I think, we'll be able to see through the demo, so that now we can make the patient journey as easy as possible and intuitive according to what the providers at facility usually do. At the homepage level, we've also made some changes to just group some of the modules and also just rename some of them. And again, this is to follow, of course, the clinic stroke facility patient journey. On the new features, we've added some new modules that have been requested previously, and this is to do with the inpatient stroke ward module, and this is to support, of course, the facility also wide implementation. So I really encourage you to, of course, go facility-wide for the facilities that are there. Then, of course, on the imaging app, we've also enhanced some of these reports so that you can be able to download them in various formats, and of course, you can also do printing. Next slide, please. So like I said, I will get into a little bit in terms of now, the KenyaEMR pharmacy dispensing module. And as you can see, what has been provided here is just some feature parity comparison between what KenyaEMR has and, of course, what ADT has. And this, we've covered all of the features that ADT had, with, of course, with one or two features in terms of integration with KEMSA that are work in progress, but to add also in terms of maybe some additional workflows that we've supported within KenyaEMR that were not there. Of course, in ADT is, of course, posting of the drug bills. This is something that is supported facility-wide. We, of course, also have the clinical and pharmacy integration, meaning that a clinician will be able to, of course, prescribe, and at the same time, the person at the pharmacy will be able to see the reason why it has been prescribed and any other information pertaining about the patient, whether be it they have any allergies. These are some things that they can be able to see. On top of also, we have also added a very comprehensive drug and medical list. So this provides whatever KEMSA usually does supply across the country. We've added all that list there, and of course all other sources that also the country uses when it comes to drug and medical list. We've also, of course, provided the printing of prescriptions, and I think this is something that already I mentioned earlier. Kindly move to the next slide, please. Then we have a new feature, a new module that has been added, and this is on the case surveillance. Again, the main aim, the main driving point of this was mainly just to ensure that we have a dashboard that is as real time as possible, where we can be able to, of course, quickly identify where the gaps are when it comes to care and treatment, and of course, provide immediate action to correct whatever issues that have been found. So we've added some few selected indicators, and these indicators mainly have some specific thresholds. Let's say, for example, like when you're talking about HIV positive clients who are not linked to ART, it looks at the percentage, maybe like about 5% who are not yet linked, and to be able to, of course, raise a flag on the same. So we also have indicators we are also following on pregnant and postpartum women in high risk, and this is based on the machine learning who are not yet linked to PrEP. We're also looking at in terms of delayed viral load testing, those who were eligible and were not taking viral load. We're also looking at viral suppressed clients without, of course, and suppressed clients without, of course, an ESC within 2 weeks. We are looking at also those ones without DNA PCR results that was supposed to be within 6 to 8 weeks. And also we are looking at HAYS who are 24 months and also have no documentation of final outcome. So these dashboards will be available, and of course we'll be waiting to also get more feedback also from the facility users, so that also we can continuously also improve and of course make your work easier at the end of the day. I will stop at that, and I will invite the next presenter, Evans.
Thank you, Cosmos. I don't know if you can hear me.
Yes, I can hear you clearly.
Okay, thank you. Good afternoon, everyone. Today I'm excited to share the latest updates and improvements in our newest release. So I think let's go to slide 14, please. There, then you're in the right place. So I think let's go over the key highlights mainly. So I think we are the first point actually for a new system. I think what runs in our minds or anyone is what is new. So what's new in the release 19.1.4? So you can see there also we are happy to introduce a new module, that is the inpatient module. I think most understand it as WADS. So this one have been introduced to the new release. If you have managed to upgrade, you're going to see that one. I think maybe much of this one can be discussed later on how to maneuver or on how to use it. So the other thing I think we are missing, and this one was a lot of requests from most of us facility, especially the pharmacists, that is the ability to print the medication detail, the prescription that had sent by the clinician in case maybe they're missing on the pharmacy. The pharmacist can be able to print and maybe give to the client so they can go and buy it somewhere. So the other thing I think what we have done especially is on the enhancing on the imaging report in case maybe that need to be down outside, so that when you can print or maybe the report, if you go to the imaging, you can find the printing. Previously it wasn't there. And then next we have what we have done. Actually, my colleague Cosmos had said it well. That is the stock and billing management has been really improved, maybe especially to just if we talk of the stock, that to let's say to be kind of resemble to what ADT head to just pull some of the ideas and so the billing management, also the payments can be customized also for waiver reason. This one also everything has been really done good there. I think the second part what I can talk of is mainly the system, that is the system fixes and the updates. So mostly I think on the triage form, risk score or calculation have been really, especially on children, we've been really having an issue on the same, but this one has now been fixed. And also we have improved on the HIV and virus screening form to be better. So what I can talk about again here is about the version compatibility. I think this is very crucial and very important for those who are going to upgrade, so that we don't encounter some problems.
So the release is going to be, a release is only compatible with the OpenMRS, that is the FAR file, that is our version is 2.6.1. If you have these less than this one, then this one going to encounter several issues, maybe the script's not running, especially on the MySQL, if the version really matters. So you may find your system, maybe have a red banner there, it's not coming up. And also when trying to maybe send your data to the national database, you get some of the maybe the errors, the tables, some table not existing, or so this is really good to use this tag, the 3.x latest. But if after upgrading, you need to see it down there. I think it usually gives us a version, so you can see that our version maybe is, so maybe it depends. You can see it's 3 dots, but the main thing is the 26 at the end. It can be 26 or 2.6. That's when you can tell you are on the latest DWAPI. I think before we close this one, we can't forget about what is next, or what do you expect at the next. So, for example, I think there's this issue, like you find the client has been the queue. Maybe the time that client came in the morning, you can find like after 10 days that client is there. So it will be out of check out. I think we have a scheduler for the same. So if this one is on, then the queue, I think it's going to close. And so the next thing I think we have we have done is we're going to do is the primary diagnosis. Okay, if you go to especially for medication, or maybe for order, if the orders have been given, the lab personnel may need to know what clinician or what the purpose of what have you sent here for. So these one are going to be as a tab. You're going to see this, or maybe the diagnosis going to be provided, the clinical history for this, maybe there's a lot of the details on the same. So, and also we are going to add next the more details on drug order tracking, especially on the when dispensing. You're going to see, like, when dispensing, you can able to tell which pack size that you're using, and maybe so that during dispensing we are dispensing the correct drug. So I think the next thing also we're going to add in the next release is about the next of kin. We'll be adding the patient profile better recorded to keep it. So for example, I think right now we only have, if someone has a contact or maybe the next of kin, the only thing that you see there is the phone number, but you don't know which phone number is it. So for example, if someone has a lot of the next of kin, let's say we have guardian, we have also the parent at the same time linked to the patient, the only thing that you see under contacts for the next of kin is just the number. So you can't tell which number is this. So in that case, we're going to add, or rather we are going to add on the details. That is the name of that person of next kin, or the name of which that phone number belongs to. So I think we can, so for more details, I think this is just a snapshot. These are very, very, very few about detail, maybe what I've said, what I've shared. So for this and more, if you want to see what has been included in the release, I think it's best that we can access our release note. That is, if you go to the release itself, you can see that a note there, or maybe you can access, if you are able to access this presentation, then if you click this release note, it will take you there and read more and get to know what is there. So I think we are here. I think what I can say, we are striving to improve our system for that we can really care for our client. Maybe if we can move to the next, I think this is the most pinpointing actually. Okay, let's go to the next slide, please. This is, I think, this is the most important thing. So now let's go. I think we are here. So this is user acceptance test feedback. As you know, UAT, I think, is a critical phase where we gather user inputs, identify issues, and make also the necessary improvements before full deployment. Based on this process, we have addressed key concern, 3 main areas. I think that is system stabilization, and performance, that is the main thing, and also the appointment and visit management, and also going to look at the clinical workflow and adjustment. I think let's take a closer look at each maybe category. I think this is, I've done just a snapshot, but more main things are going to see it on also in the release note still. So I think in terms of system stabilizing, I think we had, I think everyone can testify. There's when you log into the system, mainly you're going to find a notification that maybe there's a module. Some modules have not been resolved. So that one, we have really tried our best and fixed for the same. So for now, we will upgrade to the new, we're going to upgrade. I think that always will be for the last time we're going. I think the version that we have is the last time we're going to see that notification. So we have really managed that one out. So for optimization, so we had a problem of maybe the previous script execution took up to 45, up to, that's the approximate maybe you're getting from the facility, causing delays and in efficiency actually. So actually our team, we have worked on optimizing the system performance by reducing the execution time. By this I mean, so we had to definitely split if we go to the ETL management now, so we have introduced the ETL called facility-wide refresh tables. So it's not linked to recreating ETL, because we came to realize that in terms of the people who are using the facility-wide and they're using really the billing. So that was the pinpointer to why the system was taking longer. So for this case, we have split really for the two ETL, so they are on a separate thing, so can be run differently. So I think the other thing that we had an issue is the queuing. That is the average waiting time. That one, I think it was just doing accumulation of all people that were in the system, but now it's being done individually. And also what will help us is what I think I said there, auto-checking out, maybe removing someone from the queue rather than staying there for 24 hours. But that one also, I think that there are some fixes we're going to improve on the same, because you may find others, they're supposed to stay maybe waiting for the inpatient client, let's say for the patient clients. You can see they're still on the queue. So that one is also, there's a kind of improvement going to be done there. So next, I think I can move to the appointment and visit management. That I think this is a very, very, very important part, especially for the HIV clients. So I think previously, I think I can start for the one that I think would disturbing most of people, especially for peer educators. So if you are downloading the appointment list for that day, I think they were missing some of the phone number field was there, but it was not really pulling. So we have done our best and and made that one available. So now if you upgrade and you try to download the appointment for that day, you're going to see that phone number and also even the time. So I think the other thing, actually, this is a recent thing. This is for printing. When you try to print the HIV patient summary, especially for maybe you want to transfer out client, you want to give that client to go with his record, the snapshot record, that is the details. So I think we had a problem. It was only printing some of the parts. That is maybe one page, this one. So that one has been improved. That is capturing everything as it is in the system. So the other thing I think we have done there most is on the, if you go to appointment module, that's tab, we found that missing, we have a missing column, we have a missing tab and completing tab. So I think this one may need also maybe the understanding, especially when you're checking the client. So this one may lead to the capacity. I think that they can go and advise this one. So this one is have been really fixed, this one, especially on the complete and also the missed appointment. I think missed appointment, this one we had advised earlier, is good that we have a scheduler for this. So this scheduler, if it's not turned on, then we may have a problem. This, I think by default now it's going to be on, but maybe timing is necessary for the facility to set. So if we move on to the clinical workflow, maybe enhancement. So some of the things that maybe pinpointing, we have some of the problem maybe on the labs, especially on the labs. Labs, one thing we can talk of maybe the results. Somebody can maybe add the results to the system, but if you go to the results viewer, can't see it. So the other thing is also concerning the same. The results, if you go there, you can find a lot of tabs, like we have VL, we have CD4. Yeah, but if you check, it's not, maybe you can find it's showing you only one results, maybe the gas panel itself. But now we have done it like a checkbox. If we just check if it's the VL, it only shows the VL results. If it's maybe the gas panel that is on the temperature, you're going to show that one. And also just removing unnecessary, maybe someone has not been done, like the gas part, the temperature has not been done to a certain client, but we will find that as among the checklist. So the checklist there, you're going to see only the things that have been done to that client. So I think the other thing is full access of the form, like the post operation. This one was, I think, was due to validation. So I think now it's close to open. I think the other thing is resolved. The peer calendar, maybe it was difficult to add maybe a peer calendar on the, to add a peer. I don't know, is the educator. So I think if you can go to the next slide, please. Good. So I think next, I think I've talked about the DWAPI, that is me. So I think my colleague Cosmas has talked about some of the changes. So remember, the EMR is a bit different, so it's not the same system. So the EMR is where we pull this one data to the DWAPI. So actually, from now, if someone has loaded and be keen on your on what you have loaded from the system, maybe for the 3X, you can see that some of things have changed, especially on the profile, the CAN thingy. So we have changed also the gender. Is not, we are not using the gender, we are using the column as sex. And also we have introduced some new columns for SHIP and SHA. And then the GBV screening has changed to the screening. And also the transgender. Please, you can go to the next slide. So actually, this is just a picture of what I was talking about. So you can see here we have the violence. Previously, you can see it was gender-based violence screening, but now we are using just violence. Next, please. I think up to that point, I can invite Paul maybe to continue about maybe explaining more further and how they are really maybe adhere to the instruction that maybe were given after this waiver. Thank you, Paul. Paul Tusi, I don't know if you can hear me. Hi, Sambok.
Evans, sorry?
Okay, I think it was supposed to be someone else. Maybe. Paul Tusi is supposed to continue this section.
Oh, Paul Ntuzi. Sorry, I think I had some challenges with network. I thought it was your end, but I think it was my end. So, Paul, I don't know. Just give me a minute. I think I hadn't. Paul, sorry, apologies, Paul. So you can, Paul, you can go ahead and unmute.
Oh yes, thank you, Sambok. Sorry, I was unable to unmute myself. Okay, yes, thank you, Evans. My name is Paul Tusi, software developer in the data warehouse team. So I'll just be giving some few updates on the national data warehouse. So we have two major changes that we have made, and this will probably affect a lot of people who use the national data warehouse portal and the self-service platform. So the first change is on conformance of certain data points. So there is a revision or an update on the gender column, and this one has been now updated to sex. So this update, they said, with regards to those who use self-service, there's a chance that those who use the platform will find that a number of their charts that were dependent on the gender column will probably need some work, as they will probably be broken because they will reference a column that no longer exists. So there's going to be a need for a manual intervention on this. So we will expect users to at least go to their charts and update all the references from gender to sex. But as we go over to the next slides, we'll be giving you just a brief update on how you can be able to achieve this. And the next bit is the next update that is on password. I can just go back to the slide, to the previous slide. Yes, the next update that we have is the password reset of the National Data Warehouse accounts. And this is just to conform to our security policy. We initiated a reset of all National Data Warehouse accounts. And for you to regain access, you will be required to change your passwords, that is, and set up a new password. Again, also with this, we'll give you a guide or a SOP on how to achieve this. So we'll start off with the conformance issue, and that is on the change of the gender column. We can move over to the next slide. Yes, so this is, for those who are familiar with self-service platform, this is an example of a chart that you would normally interact with when you're creating your own visualizations. So on the far left, you usually have the list of columns that you use to visualize your data. And from there on, you can see that this is the gender column. And this is the column that is now going to be changed to sex. So you'll find that usually make references to the columns in the query section, and that is the area that has a red border that is in the middle. So this is where you'll have to change the reference from gender to sex. Just to note that this change will take effect as soon as we've done the monthly refresh. So once that one has been done, we'll pass out some communication. Then you'll be able to go to the self-service platform and rectify or fix any broken charts. You can move over to the next slide. So you can move over to the next slide. Okay, sorry. Another bit that is also going to be affected, just go back. Sorry, let's go back to the previous slide. Yes, thank you. So still on terminology compliance, the next bit that is going to be affected, other than the charts, is any filters again that were relying on the gender column. So in this particular case, if you can set up filters in any of your dashboards and you are using gender to maybe filter your data sets, this is something that will also need to be updated. I think you can see this on the left side of the share screen. This is an example of the gender filter being used. I can move over to the next slide. Yes, so for this, there's the process of just updating or editing this filter. Again, an SOP will be shared afterwards, but this is just a short guidance on how to achieve this. So you'll be able to just say that you want to edit your filter. From there on, it will bring you a list of all the filters that are available. You choose the gender filter. And once you choose the gender filter, they will bring a form that has the details about that filter. And you can change the column that it references. So in this particular case, if it is to reference gender, just now change it to the newly updated column, which is sex. Thank you. You can move over to the next slide. Okay, so now we are going to move over to the next National Data Warehouse update that we mentioned. And this is concerning account resets. So we reset all the National Data Warehouse accounts, and we'll be requiring all users to create new passwords, that is credentials, so that they can be able to access the portal and also the self-service platform. So you'll notice that on your next login, if you have not done this, you will notice that you are not able to log into the platform. You'll probably be met with this error message that says that you have an invalid username or password. So in the event that you get this error message, what you'll be required to do is just click on the forgot password link. So on the login page, you can see this one is at the bottom, just to the right of the login button. So once you click on that link, you'll be prompted to enter your username or email. This is your data warehouse email, and the reset link will be set to your email account. From there on, you'll be able to create a new email, a new password, sorry, and from then on, you'll be able to log in and access the portal or the self-service platform as usual. So this should be a quick bit, but if you encounter any issues, of course, you can always feel free to reach out to us so that we can assist you with that. From here on, I would like to invite Marianne. Thank you.
Thank you, Paul, for that. Good afternoon. My name is Marianne Wakarinde Mwangi, working in health informatics at Palladium KenyaEMR19 project. And quickly, let us look at the current implementation updates. Next slide. Platform upgrade from KenyaEMR 2.x to KenyaEMR 3.x started sometime last year. And by the end of June 2024, there was a 3% migration rate that was realized. And we needed a lot of collaborative efforts. And this came from the various HIS partners, implementing partners, KenyaEMR TOTs. And we can say that now the migration rate steadily peaked from October 2024, when initiatives among all these collaborative partners were put in place, up to now the current migration rate that is at 96%. Next. Currently, we have around 2,474 health facilities that are actively utilizing KenyaEMR and reporting on a monthly basis to the National Data Warehouse. Of these facilities, all level 4 facilities have achieved 100% migration to KenyaEMR 3.x, with only a few level 2s, level 3, level 5, and level 6 sites that are contributing to the 6% of active EMR sites that are still on KenyaEMR 2.x. Next slide. As at the end of Q1, we had at least 16 counties that have managed to achieve full migration status, and the remaining counties are also expected to fully migrate to KenyaEMR 3.x as at the end of Q2. Next slide. Similarly, when you look at partner support for these particular facilities and the facilities they support in terms of the migration to 3.x, we think that 22 partners supporting the counties countrywide have implemented, in implementing HIS solutions, have at least achieved 100% migration, and the 11 partners are expected and highly encouraged to transition fully the migration process to KenyaEMR 3.x by 31st March this year. That is by the end of this plan. Next slide. The HIS partner, that is Palladium and other HIS partners, are no longer supporting the development or any future upgrades of KenyaEMR 2.x. Now, what this means is that facilities still on KenyaEMR 2.x will not be able to transmit data to the National Data Warehouse, since this version will not be compatible with the current DWAPI transmission tool. So why are we advocating to transition or migrate to KenyaEMR 3.x? This is because the current version, especially more so the new release 19.14, it meets the NASCOP guides on the new tools revisions. And as well, it has also incorporated standard patient management workflows It is also compliant with the current USD terminology revisions, as we have seen in the previous slides. And as well, the version fully supports an end-to-end HIV integration needs for facilities to be able to offer comprehensive patient care, commodity management, and also offer real-time linkage to other facility departmental services for support, for example, laboratory, imaging, and billing as required. Next slide. So the HIS partner, Palladium and other partners are keen to support the remaining 74 facilities to upgrade to KenyaEMR19 before 31st March, by the end of this month. And currently, we have ongoing mentorship support to the EMR TOTs on the current version changes, and that is something that should commence immediately when all the sites have upgraded to this version. For upcoming activities, the HIS partner is currently working on organizing for virtual trainings on the new features and enhancements on the new version. Then again, we're also keen on supporting 100% of system upgrades from the current 19.13 to ensure that all facilities are now on the version of 19.14. And we're also looking at piloting e-claims and HIE registry integration in 5 facilities from 4 counties. Then from there, we will be able to give feedback and hopefully transition all facilities to be able to utilize these particular features. Next slide. So the Palladium KenyaEMR partner currently supports continuous capacity building efforts by the use of various or different materials. And from all the developed HIS solutions that we currently support. So currently we have updated guides. We also have SOPs available from the project website as from the link that has been shared. And we also provide short to-do videos that are user-oriented as job aids that that are available from our YouTube channel. And again, the YouTube channel link has also been shared. Next slide. The project is also committed to offer required support, both at the TOT, the county TOT level, the partner TOT level, and even at the end user level through our service desk team. This particular team is available during weekdays, working hours, and they can be reached through a toll-free line and a SpiceWorks issues ticketing platform. I can be able to see the toll-free line. Users can be able to call, no charges or implications will be on their end. And as well, we have a dedicated email that users can be able to reach out for support in terms of system upgrades, technical errors, resolution that they may be seeking, and also to book for administrative technical training as required, and also air any enhancements they would like to see within KenyaEMR. That's it for this particular session. Back to you, Songok.
Thank you. Thank you very much, Mary Ann, Cosmas, Evans, and Paul for taking us through that first part or session 2 presentations, basically just focusing on the highlight of the changes in KenyaEMR, the features that have been enhanced, and just looking at what is new in terms of the dashboards that have been developed to support surveillance, and just Marianne taking us through the last part on highlights on what exactly we expect, and sharing with us contacts or toll-free line and the email addresses that if you have any challenges, you can always reach out to the team. The team is always available during working hours, and I think he's just taken us back to that slide because I think someone had asked a question regarding the same, whether we have an email address where we can channel all the issues or all the challenges that we face in our day-to-day service delivery points. Right, so at this point, I want to usher in Eric and Evans again to take us through the demo, and then after that, we will open it up for Q&A. I don't know whether it's Eric starting first or Evans. Oh, Magdalene. I'm informed Magdalene. Magdalene is going to take us through the demo. So Magdalene, you can take it up.
Good afternoon. Hope you can hear me.
Yes, I can hear you. Go ahead, Magdalene.
Okay. Let me share my screen. So I hope we can all see my screen. Is it visible?
Yes, it is visible. Go
Okay.
ahead.
So I'll just be taking you through the changes that has been made. So I'll start with the homepage updates and rearrangement. So after you log in, this is our homepage where you'll still see the homepage where you have the active visits for that particular day. Then you'll notice that we have patient services, which has been collapsed. So the patient services right now has the service queues and appointments. So you remember service queues and appointments were like a standalone on their own. So right now they have been grouped to patient services to enable more of the clinical workflow. So the person who is doing mostly the service queues is the one who does the appointments. Then after that, we have the MOG module, and we also have the introduction of the inpatient module, where the inpatient module, just a minute, sorry. Let me change something here. Yeah. So for the inpatient module, you are able to admit someone. So here you'll be able to see your admission request and also all the beds that are occupied and the beds that are not occupied. That is the empty beds which you are assigning to someone. So there's an SOP for this. We'll get this after the demo. Then after the inpatient module, we have the claims management, which goes hand in hand with the wards or the inpatient module, which this has the claims overview where we have the claims, a dashboard on claims that have been claimed. Right now, we don't have any, and also a pre-auth. So if we have any pre-auth, we can see like on 24th October, we had a pre-auth for Sarah that was on insurance. Then you are able to see all the provider and the intervention code and if it's active or not active. And then we can mirror them to what is a draft, what has been cancelled, and also what has been entered by error. So this goes hand in hand with the inpatient module, and it also claims to the SHA and SHIF. Then we have the linked services, which are the services which are used to link the patient, where we have the peer calendar. Then we have the case management module and also the community pharmacy module for the pharmacy dispensation. Then we have the billing module, where the billing module, we have the overview, where this is the cashier's overview. They are able to see the today's bills and all the patient's bills. Then we have exemptions, which this is more of an admin, where they are able to do the exemptions for the services, which want the services to be exempted, and also the commodities. So this, the admin is able to configure this. Then we have the charge items, where the charge items, these are the items that are billables or are payables in the hospital. This is where you are able to add them. Then we have a bill manager, which has more of the waiver services for those patients who you are doing waiver. And then we have the payment methods, where you are able to configure the payment methods that you have in your facility and also able to see them at a sneak view where the payment methods you have. Then you are able also to configure the payment points or the cash points. If you have different cash points in your hospital, you are able to do this. If you have an OPD, an IPD cash point, and maybe something in the children's ward, you are able to configure there. Then we have the payment history. This is a more of an admin dashboard where you are able to see all the payments that have been done for a particular period, and you are able to just filter them maybe by the service type that is configured, maybe by payment type, and also
Maggie, are you able to zoom in your screen a bit? The print is too small.
Better?
Yes, yes, much better.
Okay, so where do I start again? Or we are
No,
okay?
you can just pick it up from there, no problem.
Okay, so for the payment history, you are able to see the dashboard, and then you are able maybe to filter by which date you want, the service types, the payment types, and also maybe by the cashier names if you have different cashiers. Then we have the diagnostics. These are for the providers where we have an imaging order. These are also the radiology orders. This is just the dashboard for the radiologists or the sonographers, which they are able to tackle it from here. Then we have the procedures where we have the dashboards for all the procedures that have been sent, which are done either by clinicians or the nurses. Then we have the lab view, which is seen by the lab technicians or the lab technologists, where they are able just to take their test and continue with the sample processing. And also for the lab people or some of the clinicians, we are able to have the lab manifest, which the lab manifest will have the dashboard on the overview, where we can see the TOT time and also all the total manifests that have been there. Then we have the manifest workflow itself, where we are able to see the dashboard of all the manifests that have been entered and any action that can be done. And also you are able to add a new manifest from here. So this was just collapsed so that we make this view a little bit organized. So also this view just comes dependent on how you are logged in. So it is more of provider login. So how you log in. So if you are a lab person, you won't see any other thing. You just see maybe the diagnostics. Same as to all other providers in the hospital. Then after that, I'll go to the next one, which we have the terminology compliance. So for the terminology compliance, we have the different forms. So for the different forms, we'll start with the forms that have been affected by the terminology change, which was the dropping of the transgender, the trans woman, the trans man, and also renaming of the GBV to violence. So I'll start with the first form, which is HTS eligibility form. So allow me to expand this. So for the HTS eligibility form, the first dropping was on the population type, where on the key population type, we add transgender. Right now, you can notice that the transgender was dropped. We are only remaining with the 3 people injecting drugs, FSW, and people in prison. Then there was renaming of the GBV to violence screening. So we add a session on the violence screening, which here was previously GBV, as you can see the place I am highlighting. So right now it reads on violence screening from the GBV. So that was the change in the HTS eligibility. Then from there, I'll go to the next form, which is the HTS initial form. So for the HTS initial form, let me expand this. So on the recordings, we add on the KVP population, we add the trans woman and the trans man for the different KVPs. So this is a female. You'll notice that right now we don't have the trans woman, so that has been dropped. Same as for the male gender, we don't have the trans man, that has been dropped. This is the HTS initial. Allow me to discard this and go to the next form. So the next form is the HIV green card. So for the HIV green card, we add a session on the GBV. So let me open this. So this is on the patient management. So on the patient management, we have, as the client being a victim of violence, this initially read as the client being a victim of violence of GBV. So this has been changed to conform to the terminology change. Then on the next one, I will go to the PrEP. So I'll go to the PrEP forms. So for the PrEP, we'll start with the PrEP behavior risk. So PrEP behavior risk. Just a minute. So on the PrEP behavior risk form, there was a question on the behavior risk of the partner, which read on ongoing intimate partner violence or violence screening, which read on is IPV and GBV. So right now that has been changed to violence screening. Then after the PrEP behavior risk, we have the next form, which is the PrEP initial. So on the PrEP initial, form, there's a change on GBV where this was renamed on starting, just a minute. Yeah, on the PrEP treatment plan, when you click on the start, we have the reasons for starting on PrEP, where we have ongoing IPV stroke GBV. That was initially GBV. Right now it's reading on ongoing IPV stroke violence screening. So that was the change to conform to the gender terminology change. Then after that, we have a change on PrEP monthly form. So on the PrEP monthly refill form, we have on client assessment. On behavior risk assessment, when you click on yes, we have the client was assessed for ongoing IPV and violence screening. So this year read as ongoing IPV and GBV. So that has been changed to conform to the violence screening gender terminologies. Then we add a form on the GBV, which was a standalone GBV form. Right now, it is the violence screening form. So this is the form. Right now, you won't find the GBV form. It will read the violence screening form, where we have this changed, the label has changed, and all the questions that were reading GBV have been changed to read violence screening questions. Then after that, we had the introduction of the GBV module, which has been changed to violence screening module. So you'll be able to find here when you want to enroll someone to the violence screening, to just know which screening, the violence they have subjected to, you are able to just see it from here. That is the violence screening form. And then after that, we'll have all the consequent violence screening forms. So this was highlighted in the improvements that were done. So we have the different violence screening forms, the violence forms that are here that conforms to physical, sexual, and emotional and trauma violence. So after the terminology compliance, we have the regimen where there was addition of the 2 regimens. So for the adults, we have addition of TAF LD. So maybe I'll just highlight maybe when I want to change, and then I'll go to the standard regimen, the second line. And for that, you'll be able to see right now we have the TAF LD for adults as the second regimen line. Then after that, we'll go to the children. Just a minute. Yeah, so for kids, we add the addition of also the TLD for children. So when you go, maybe we want to change, and this is use of standard regimen, and this was child second line, we'll see that TLD has been introduced for children. Then after that, we add an highlight on the case surveillance dashboards. So this is just to highlight where you'll be able to find the case surveillance dashboards. So when you go to your KenyaEMR modules, you are able to see the facility dashboard from here. So when you open on the facility dashboards, you are able to see the real-time case surveillance dashboards. as they were talked in the demo. Thank you. I'll invite Evans to continue with the demo.
Thanks so much, Magdalene. I think I can share my screen. I don't know, maybe Songok, I don't know if
Yes, Evans, I can hear your voice. We're waiting for you to share your screen.
It's a bit refusing to share. I don't know if there's a maybe blockage or something.
Just give me a second. Let me just check. No, you are able to. I don't know why you're not at the moment, but you're able to, because I've given you the powers to, or the rights to be able to share. Try again. Try sharing again.
Let me try. Let's see. It's really not showing anything. I think that share button, I don't know. The share button is refusing.
You're not seeing share screen. The green button at the lower
yes,
part, just between
yes.
reactions and security. You're seeing it?
Yes, I'm seeing it, but if I click, nothing happens. Just click that. Yes, thanks. So if maybe you can access QA and share your screen, I think I can use yours.
I'm not using my screen from my end, so I may not be
Okay,
able
maybe
to request Magdalene to just continue sharing her screen. Magdalene, I don't know whether you're able to access.
Yes, I can see Magdalene's screen. I think you can go back home. Thank you so much. I think I can start maybe showing at the overview. I don't know. So the previous version, I'm sure the tabs on the left were very long till you go down. So for now, I think we have just minimized them. Like if you go to patient service, is where you get. Magda, you can expand patient service. Is where you can get our service queue and appointments, so that we have to reduce that window on that side, so that it can maybe be precise. And also we have actually a lot of many. So the other thing that I can talk about that has been added there is about the providers. So I think previously we have been going back. If you want to add our users, we have been going back to maybe 2x and maybe trying to do some of the things there. But so this one has been moved to our 3x. And also, if you want to maybe to add the user itself, I think there you can go to the hamburger. That is the where you get KenyaEMR dashboard. There, the admin. We have the admin. No. At hamburger, just go back to 3x. Just go to 3x, please. Go back to that hamburger selection. That where you get the dashboards and the 3x3 dots here there. So you can see there is an admin app here. You can click the admin part. I think that one can explain maybe what you have. So the admin part is where you add our users. If you go there, you can see our users here, their roles and wherever. So if you want to add the user, you don't need to go still to 2.txt the way you are going back recently. So, and then you can, after adding the user, you can add also the provider on the other section. So on the same page, yes. I think that one is so you have some section, the demography, you have the log information, the roles, and where you can get for the purpose of the stock. you go to an additional. So these are the normal roles that we have been seeing. But on the stock roles, you need to go to the advanced additional roles where you can get the stock roles, and then maybe you want to make that person which location that person need maybe to be logged. Is it is an admin farm? So this one, and then you can select. I think what we have been doing on the stock management has really also been pushed back to what we have in in 3x. So this one is user management has been actually it has been brought to one location, and also for the if you can close this that one. So before even I go to that side, I think I can explain the detail. Yes, you can go to ETL. So I think previously also we have been going to 2.x so that you can do maybe the creation of the ETL. But now it has been moved to our 3.x. So this one you get to under admin, and you can get all of the what you are supposed to do, refresh tables and everything. So this is the last part is what I was talking about. We had to create the facility wide tables to reduce the number of maybe the time that was taken, and the system really was going slow. So that one we added that one. If you go back maybe to providers, can go back home. No, just click KenyaEMR home. So if you can open providers. So on providers, I think these people is if you try to edit one. So the providers section is where maybe if you can find the facility, maybe the providers has got maybe the license. Then so you can really use maybe the expiry date. Everything is being provided on that section. So you need the number, and also this one will be some section is going to be pulled. I don't know if you put the ID number. I don't know if it's. I think we're going to maybe to help on this one, because sometimes it's pulled from that registry, and maybe the number. I don't know. I know maybe providers understand it well where the numbers, the license number for operation is getting from. So this was going to do on that section. So maybe I can move to the next thing. Maybe if you can go to just go home, and then we pick one. Let's pick just one client. So one thing that maybe also if you go to if you come to the patient, also the list on the left, those menus, they were extremely longer. So some of them has been minimized to one tab. Like if clinical consultation is where you get the medication, your orders, the results, and allergy and conditions. And also we also done on the diagnosis. Oh, I think that one I left to the other side. So that is it. So actually this one I had explained about. So I want to talk about the results view. I think this one I had a problem previously. We go to the results view, that one there. So actually this patient has one. For example, this patient only has the VL. So you only see the HIV viral because the only test that has ever been done to this patient is HIV viral load. Otherwise, if you go back to a patient called, go back home, the same, there's this patient, let me tell you, that is, no, that one, the hoodland, the queen tuna hood one. No, the blue one, yes, that one. If you go to the results view for that patient, yes, you can see this patient has got. So whatever that you are seeing here on the left side, these are only the test results that have been done to the patient. So previous, or if you have the previous version, you see this one under the tests. You'll see all the tests that are on the system. So maybe you are supposed to mark. But for now, the tests that you are seeing on this section are the only tests that are done to the client. So Maggie, you can help on if you can go and check maybe one. You can even check the VL. There's a checkbox after each, before each. No, they're on the left side. That's just so if you tick VL, you only see the VL on this side. There's nothing. Everything is closed. Maybe you're interested in the VL itself. It's going to see that. Maybe we're interested in VL with other. We can even close. You add that one. It's going to be added. You can close the VL. The section, yes, you see the UI, only your VL is going to be, the VDL is going to be shown. So this is the improvement that I've done on this section. So I think the last part that I'm going to show is on the printing of the printing of the maybe appointments. Maybe you can go to home and then you go to the patient service appointments. I think it is. So if you try to maybe just download those. So you maybe want to download those the list, and then we go to that to open. Yes. So previously, I think we had the challenge of maybe having the telephone number. So our phone numbers here, they're not here. We have used the dummy phone numbers for those clients. If you pick the one, you can see it belongs to that client really. So this one was a problem, was an issue, especially to our peer educators or the one that are maybe locating our defaulters or the one that have missed. So this one have really been added. And then also the type of the appointment type, I think this one has been really added, and also the gender and the age of that client. I think for that Maggie can go back. I think there's a last thing that we need really to talk about before we close. It's a good. So if we go, so there's this. Let me see. You can open one client here. I want the client that we can check in that has an appointment. Maybe I think let's check it. Let's try done. No, that one's checked already. Maybe we can use who? Patient appointments. Maybe just try Victoria. I think Victoria is okay. That's okay. That's okay. That one was not being checked in. Okay, when check in, actually there's something else was added for the purpose, for those who are saying like we have the patient have been really completed from the facility, but you can't see them in the complete or the checked in client. You only see them if you have really checked one, maybe the patient has come for which appointment. For example, is a cervical cancer. I think this one was created as a multiple or not recurrent or what. So this one, if you don't check that one, let's say for what are you checking this client for? Is it for which appointment? Then that client won't appear on the section of the checked in. And also, if you finish on the client and then the other section. So this, I think there are people who are asking why, like we are checking the client and you can't see them on the other side. And also for the purpose of completion. So during check-in is an advice. Please really just check in the appointment or just select the appointment that patient has come for. That one will save us and it also will just reduce these. Because if we do like maybe that client has not come for that, or he had maybe an schedule for that day, but he didn't come for that thing. You see that one we can include like as check-in because the appointment that is under the appointment has not been maybe adhered to. That's why you can't find that client has been selected as check-in, and also during the completion of the service you can see that client. Thank you, and back to you, Songok. Thanks, Magdalene.
Yeah, thanks. Thanks, Evans, and thanks, Magdalene, for taking us through the demo. We really appreciate just to make us understand and internalize the first part of the presentation, so that we're able to appreciate some of the changes within KenyaEMR. Let me also mention at this point that we already shared the release notes. I'm sure most of us received a mail that came from us at NASCOP sometime last week, just providing some guide, but we thought it wise to just have this webinar so that we can also respond to some of the questions that you have and also just provide further guidance on the same. So I think at this point, we can go to the Q&A regarding the demo and also regarding the slide presentations that we were taken through by Paul, Marianne, Cosmas. So I don't know whether there's any question. I know the team here has been available to respond to most of the questions that I've seen on the chat. just in case you would want to verbalize any, or if you have any question that you want to verbalize, I think we can give ourselves an opportunity for about 10 minutes before we close. I can see it's 3:39, so we need to close this by exactly 4. We don't intend to go beyond that. So any questions? You can raise your hand so that I can give you the mic. If you have any questions, so let me just... All right, I presume most of the questions have been responded to, but I think there's one that I caught from Robert Kinoti, whether consultations were done before effecting these changes. My response is yes. Leadership is very much aware of this, and it was necessary. However, it doesn't affect our reporting at the end of the day, because remember, we're just renaming some of the registers, just changing some words based on the guidance that was provided. So consultations was done, and discussions were done, and that is why I think if for those who are in here, Dr. Lily was in the call. So of course consultations were done, and it was agreed that it is necessary for us to take up this and probably just comply on some of those changes that were requested. Yeah, I can see your hand, Robert, so you can go ahead and unmute and speak.
Thank you, Songok and the team. Good afternoon.
Good afternoon.
It was good afternoon. Actually, getting information or updates on the KenyaEMR updates. Of course, what I was I had asked on the chat is not what you have actually put it across, but I meant that this, we have at the county levels, we have structures whereby service providers, like not really service providers, but coordinators have been assigned responsibilities against some service provision like the GBV, and of course some positions created. So it was just on a right note whether we are going to move away from GBV coordinators to violence coordinators in quotes. Thank you, but
Robert,
that was on the right note.
No, I understand.
However, I have some questions. One, I need to be confirmed whether these KenyaEMR updates, we understand that now it is more or less of facility-wide EMR, and there is the adoption of the ICD-11, and especially when we are dealing with the outpatient and inpatient. So I just need a confirmation whether ICD-11 has been configured in KenyaEMR. Two, I looked at the inpatient module where you are able to note their beds which are vacant, which are occupied. I don't know whether the system is able to think like the realities that are there on the ground, and we experience more than 100% bed occupancy, especially in some public facilities. How will this be managed within the EMR? 3 is on the unique identifiers for patients that are being managed by the KenyaEMR, the facility-wide. Is a unique identification going to be assigned by the system? I think those are some of the questions that I'm having as of now. Thank you, and over.
Thank you very much, Kinoti, for your questions, and of course just for clarifying your concerns earlier. Probably I may have gotten it wrong, but I think we are now in line. I think that the positions at the county level will not change. I think what what we've just done is just to be able to rename some of the tools just to comply. But in regarding the positions at the county level, that will not change. And if in any case they were to change, then I don't think NASCOP would be in a position to really speak about that. That can be discussed at a different level. But for now, I know that there are no such changes. Then I think you had 3 questions, and I just want to request the team to respond to. And I think most of these questions are, I think Eric Mudomi, I don't know whether you are able to speak, Eric or Maggie, whether you want to respond to this. Let me just see. Eric, I need to give you the mic. Okay. Yes, Eric, I don't know that it's you who can respond to them. You can now go ahead.
Thank you, Songkok, and thank you, the team, for offering your time to get the updates that we've done within the KenyaEMR. And thank you, Mr. Kinoti, for the 3 questions. Let me start with the first question. Yes, KenyaEMR is a facilitated system right now, incorporating all the services that you can be able to offer within the facility. That's the reason as we can be able to see inpatient being demoed by Margaret and even mortuary module within the system. The first question on the ICD-11, yes, we are halfway including all the ICD-11 codes within the system. So that is something that KenyaEMR has taken care of. Then the next question on the inpatient, when the demo was being done, maybe it was very fast, but you could be able to see if in one ward we have, let's say, 2 patients sharing a bed, that is possible within the KenyaEMR. We can even be able to assign more than 100% occupancy rate within a ward. Then the third question you ask on the unique patient identifier, whether the KenyaEMR will be giving, and this one I'd be directing it to the HIE, that is the Health Information Exchange, whereby each and every patient now will be given a client, the CR number, that is the client ID, that will be able to uniquely identify you. The purpose of this is that even if, let's say, Meru is using KenyaEMR, and then you move to Busia County, whereby, let's say, they are using Tibabu or even Afek, they can be able to query using the ID number, and they'll be able to pull the shared health records through this CR number, which will be uniquely be given to all the patients visiting our hospitals within our country, Kenya. Over to you, Songok.
Yeah, thank you very much. We can take more, and then we summarize. We can take one more from David. So, David, you can go ahead.
Thank you for the time. My name is Dr. Kwom David from Kisumu County Government. My question is on the pharmacy module. Previously, with the 3.x, we had challenges dispensing drugs to patients who are in the wards, because we kept on getting an error that there is still pending bills to be cleared. So the first question would be, has this been improved or sorted out for us? The second part of the question, now that we are having facility-wide implementation of KenyaEMR in most facilities, is that surveillance database able to capture more critical indicators, including those of NCDs, for example, patients with poorly controlled blood pressures, or the sugar monitoring indicators, maybe the random blood sugar? Lastly, I've not heard much about the report generation, though there was a demonstration on how you can filter, for example, for the administrators, on how we can filter the transactions by date and maybe payment method. Could the facilitators maybe say something more about the reports? Thank you.
Thank you. Thank you very much, Doc. Yeah, so I think the team can respond to those. So the first and the last question, I think, Eric, you can respond to that. And then Paul and Tusi, you can respond on the surveillance question. Eric, go ahead.
Thank you for the questions from Kisumu. On the first question, I think it was related to the inpatient module, whereby if a patient was admitted, you couldn't be able to dispense the drugs due to a banner appearing that you need to clear a certain bill. Right now, even with the current the new release that we're going to do, you can be able to try these. When you're checking in the patient and then you specify even the payment mode and then the inpatient, the system shouldn't be able to block you to offer or to be able to dispense the drugs. The Kisumu team can be able to test that and then be able to give us feedback, because this is the first time, again, we are going to release the inpatient module so that you can be able to get more feedback from the team. We will be able to appreciate your feedback. On the other question, before I hand it over to Paul Ndusi, it's on the reports. I know we did not have a bit of more on reports generation, but I think it's something that maybe in future, or maybe in another time, we can be able to look at it and organize on how we can be able to show the reports generation. Over to Paul.
Yes, thank you. Sorry, just wanted maybe to ask a clarification on the question on the surveillance. Do you mind maybe just asking the question again?
Maybe, Paul, the question was, this is Eric. The question from Kisumu was, now that we have the real-time dashboards on the surveillance, is it we able to expand that and be able to include more indicators apart from whatever the indicators that we have? I think that was the question. Over to you.
Yes, I think we only started with like a limited number of indicators, but the intention is to grow this based on the demand that is required. That is maybe the indicators that maybe seem most urgent or would require like maybe timely reporting. So we are only starting out with, I believe there's something like around 5 or 6 indicators, but this number will grow over time as we try and move towards like a way more real-time data. Thank you.
All right, thank you very much, Paul. I think we can take the last question. So we'll start with Teddy, then we go to Kevin Somba, and then we go to Ngomoa. I think I'd also seen a hand from Ruto, the CHRIO, and then we will close it up with Ladislas, and then we should be close because we only have 10 minutes to the top of the hour. So let's start with Teddy very quickly, and please let's just minimize our questions. If a question has sorry, confirm you can hear me. my laptop has gone off, so I had to switch to the phone.
Songkok, we can hear you clearly.
Thank you. Yeah, so I think we can go off. Teddy, you can go first. You can unmute. Okay, so Teddy, go ahead. Okay, it seems Teddy's having challenges. Yeah, Teddy, go ahead.
Am I audible now?
Yes, you are.
Okay, me, I have just a concern two concern on HTS self-test. The earlier one we didn't have the reports, the HTS self-test reports under the reports. I don't know if it's included. Then under the testing, under the HTS self-test, the results, where we can put the results, the clients are negative or positive. So it was not there. So I don't know, the current one is included. Then number 2, in other PMTCT module under the preventive measures, we have the client can come to the facility and have several preventive measures, like maybe the client is given the malaria, the nets, the treated insecticide nets, the IFAS, the whatever. So the earlier one was tying us so that we can select one. So I don't know, the one coming is it can allow us to select the preventive measures we have given to the client. Over to you.
Okay, thank you, Teddy. Ruto, you can go next. Okay, as Ruto prepares, maybe Ngomoa. Ngomoa. Yes.
Yeah, I hope I'm audible enough. You can hear me?
Yes, you are. Go ahead.
Yeah, so mine is more of a follow-up question from what has been asked before regarding the dispensing module. So currently we've observed that we have an issue with the drug order module, whereby if a client comes before the appointment, the scheduled appointment, the system tend to assume that these clients already have a medication. And as such, the clinicians are unable to dispense medication. And I think one of the responses that we've been given is that we can, we can modify that drug functionality. But something that we have observed is, once this drug has been prescribed, and the pharmacist actually dispense the medication, so that record is removed from the drug order list, and therefore we don't have that functionality for the clinician to modify that to modify that record. Thanks, and over.
Okay, thank you. Thank you. That's noted. The team will respond. Then we can go to Kevin. Kevin, and then after Kevin, Ladislaus Auma.
Hello, can you hear me?
Yes.
Yes, I have a question about this system updates. We've had different updates in the past. We've moved from IQ Care to KenyaEMR, 2.x, now 3.x. I don't know if the next time we'll be moving to 4 and 5. When do we get the stability of this? Because I think it will be cost effective for the program if we stuck on something than this every now and then updates. Because at the end of the day, we may not all get the training, and when getting to the system again, it is time consuming. So I have a concern about that. The other concern I have about is issues of appointments. It has been noted that sometimes we need to even tally from the KenyaEMR to get the appointments in the month, whereby you can only get a lower number or an erroneous number when you use the line list that we pull from the system. Is this current system able to do that for us? Now that you are saying that it's not able to do the reports, it's not able to produce the report. Thank you.
Okay, thank you. Ladislaus, then we can go to Kembua, Thomas.
Yes, thank you. I only have one question. We've not been able to do index testing, especially the high viral load clans in CCC. If the clan had not been screened for contact listing, you do it, the report is not auto-populating in the PNS register under the reports. I don't know whether it has been resolved with this version or not. Thank you.
All right. Thank you. Kembua?
Yes, thank you so much, Songok and team, for the timely updates on KenyaEMR, the .x. My question is a follow-up on a question which has been asked, that the system will be allocating the unique identifier for every client. My question is, now that we are going facility-wide and there are referrals from one facility to another, and even clients can seek treatment in other facilities, I'm just wondering how the other facility will access the patient's details or notes now that that's a specific client was assigned to a specific facility. So, and it also have to go in line with the now Data Protection Act, where ideally we should obtain consent. However, when a patient visit a facility, it is assumed that yes, actually there will be an implied consent. So I don't know how the other facility will be able to access the patients, the clients' notes in the KenyaEMR in another facility that they are seeking treatment or services. Thank you.
All right, thank you, Thomas. I think we will close it there. We can then respond to the questions, and then we go to call to action, and then we should be able to close. So I guess I'm hoping the team have taken note of all the questions, and most of the questions I think are directed to Eric, except one question, and I'm hoping Otieno can assist to respond to on the question around the system upgrades. When do we think we can be stable? Why the frequent system upgrades that do happen every now and then? I know it's because of the need. Remember, we are living in a dynamic world where things keep changing, and whenever there is a change in terms of how we manage our clients, or whether we want to do some bit of scale up or enhancements, we definitely have to upgrade the system for us to enjoy some of those benefits that come with the changes. But I think Otieno can speak much to, can speak more to that. So maybe Eric, you can respond to the rest, then Otieno can add up on the system upgrade changes that are frequent. Eric?
Thank you, Sonkok. And I think the questions were so many, so I'll try and respond to some of the questions, and then I'll be able to hand it over to my colleague, either Magdalene or even Cosmas or any other Palladium team before maybe Otieno response to the stability system issue. Let me start with a question on the PMTCT, and I think this was asked by, I think it was Teddy, on the preventive measures or the services under the PMTCT that the system can only allow one. So the functionality within the system where you see a button under the preventive written add, it says that you can be able to add as many as possible of the services that you've given for that particular day. It does not only restrict you to only one preventive measure that you can be able to offer for that particular visit. So there is a question that was asked on the dispensing module, that the system assumes that the drug has already been dispensed, and the reason is maybe if I just can start by describing how the system was designed. It was looking at the number of the days, or the number of the, for example, tablets that have been prescribed against the number, against when you'll be coming again back to the facility. So what basically it means that you have drugs to cover you until the last particular end date. But this has been reported, and I know the team is working on it so that can be able to allow you, even if the patient comes back, even before the tablets are over, you can be able to run again a prescription. The modification button was just a solution for the time that will be fixing so that you can be able to prescribe the drug again. Then there was another question on the index client that you cannot be able to see whatever you've documented under the PNS register. Again, we will be looking at that so that you can be able to see the reason as to why you cannot be able to generate, or if when you generate the PNS register, you cannot be able to see any of your client whom you listed under the contact when you're doing the contact elicitation within the system, why they are not appearing, but they're supposed to see all that. Then the other question that was on the system allocating the unique patient identifier. Let me clarify this. Our government, which is Kenya, it's towards digitizing even the health. So the unique patient identifier that I talked about, it's not being given by KenyaEMR. As there is a system by the name HI, which is Health Information Exchange, and I know the DHA team will maybe mention, because I know they were to be part of this meeting, whereby the Health Information Exchange, which is being run by the government, the Ministry of Health through the government of Kenya, as something we are calling the CR, the Client Registry. There before I know we could be able to relate to the client register that we end, whereby you could be able to give a unique patient identifier, which was very well known by most of us as NUPI. Now we have a very new one, CR, whereby this one will be able to assign each and every Kenyan a unique identifier that we can be able to use. How will this one work in relation to the shared health records, whereby you are talking about the Data Protection Act? That has been, the Data Protection Act has been covered at the ministry level. So this is how the CR number will be used when you log into any system using any of the EMR. Then you request, you use the ID number for the patient coming to seek for the services. The clinician will be able to see within the system a button whereby you can be able to request for the shared health records. There is a standard set of the records that can be shared across all these systems. So again, the phone number will be there for the patient that you're attending to, or even let's say there will be a way we can be able to give to authorize. So the patient will need to authorize so that the clinician can be able to access the shared health records. This means, as I stated earlier, if I am seeking services at Thika County Referral Hospital, and let's say previously and visited Meru, they can be able, once I authorize, they can be able to see the diagnosis and the set of records that were given to me while in Meru. So this will be done through the CR. Again, it's not given by KenyaEMR. It is under the Health Information Exchange level. I think, Cosmos, I don't know whether you want to respond to any question that I may have not responded to.
Yeah, I think there's only one. Yeah, there's one that is remaining on the appointment and the line list. I think the concern was when they generate the report from the line list, the numbers are lower. Maybe probably you could, I thought that had already been resolved, but maybe you can just speak to that. Cosmas, maybe Cosmas can take that up. Then Otieno can wind it up with the system upgrade concern.
Thanks, Sungok. I think maybe I've seen that the response has been given on the Q&A. What we can do is maybe follow up with that specific facility user just to now figure out and triage if the issue is recurring at that site, and provide maybe a way forward for them. So maybe they can reach out through the service desk, and then we can be able to, of course, guide further. Thank you.
Thank you, Cosmas. Yeah, I think that's also one of the things that I wanted to mention, that we have toll-free numbers, I think, that had been shared earlier. So if you have any issues, because I know we may not really be able to address all the issues or the concerns that you have, you can always reach out to the team through the toll-free number or the email addresses that were provided. So Otieno, final one before we close.
Yeah, thanks, Sungok. Confirm I'm audible.
Loud and clear. Go ahead.
Oh, thanks. Yeah, I think this is a question that came from Mr. Somba, and I think it's an easy one. Mr. Somba, I think just to respond, no system, if you look at it, there's no system that is static, be it a manual system or electronic system. You could see even the ICD level you're talking about started all the way from 1909. That was, I think, ICD 0, all the way to right now we have like ICD 11. So that means there was a lot of improvements and changes along the way. If you could look at maybe the computers we're using, the Microsoft, I think right from 1985, when we had the Windows 3.0, it has changed and improved along the way, and now we have like Windows 11. So that is a big change, and if you look at it, the changes are for the better because of efficiencies that comes with innovation. Even in Kenya, I think from NASCOP we had the blue card. Now we have the green card. Yeah, so those are changes just to ensure that we are able to really leverage on technology and the improvements to get most efficient in our work and also in the way we work with these things. So when we moved from IQ Care, there were reasons for that, just to ensure that we could consolidate all the efforts in supporting one system so that we could improve on it better, as opposed to having different siloed systems. That again went very well, and decisions were made to now move to 3.x, which again, the intentions were clear because of the performance, because of the features that were available. So generally, just to answer your question directly, improvements and transitioning from one version of a system to another is a good thing because it helps in terms of ensuring we take advantage of the technology to improve efficiencies in our work and also in the systems, and also to ensure that we align with the developments across the globe or within the country to ensure that we are able to deliver better on our services. So that's why we move from this version of system to another. Thanks. I hope that answers your question.
Thank you, Otieno. I think that really suffices. I think we can then move on to just close the meeting because I think we are way beyond our time. So I think there's only one slide deck that I need to quickly take you through, the call to action, and I'm doing this on behalf of our SI lead, Dr. Lily, who had to drop off because of another engagement. So maybe you can go to the next slide. Yeah, so this is our call to action, or this is really what we're asking all of us to do after this meeting. We are requesting that all the teams at the county level, at the facility level, of course, working closely with all the other stakeholders to ensure that you upgrade all the sites to KenyaEMR, the newest version, which is 19.1.4. And I'm glad that Otieno has really spoken much about the reasons as to why we need to keep upgrading our system to conform with the latest technologies, to conform with the changes as required by the ministry and all the other stakeholders. Number two is our expectation is that we need to transition all sites from 2.x. You noted that from our presentation, we clearly noted that we are no longer conducting or carrying out any enhancements on 2.x. And also, if you're still operating on 2.x, so you may also have challenges in terms of uploading your report to National Data Warehouse, and hence that will affect the quality of the data or the amount of data that we have at the national level. So we are requesting that all the sites, I think it was shared at the national, at the county and partner level, but I think we will be sharing more on the same so that you can target in terms of the specific sites that have not been upgraded. So we are requesting that this should be done as soon as it's possible. We are also encouraging that all the facilities should start utilizing the real-time case surveillance dashboards. I think that was also shared with us. And the reason as to why we always develop these dashboards or these visuals are meant to communicate or pass a message to us. So it is good for us to ensure that we utilize them, we make use of these dashboards. And in this case, we've incorporated in the KenyaEMR, and this should help us in timely interventions at our facilities, at the county level, or even at the national levels. Note that all the variables that we were requested to comply or to change, that has been changed, that has been done in all the tools, especially in the EMR, and also in the National Data Warehouse. I think we were taken through some of those updates or some of those changes. And that has already been effected in the tools within the EMR and the reporting platform. Of course, I think we also appreciate the collaboration between all the stakeholders. In this case, all the HIS partners are working closely with the ministry to provide continuous virtual trainings on the release, among other HIS topics. And I think clearly from what we've seen, there are so many questions that are coming up. Like I said, we may not exhaust all the questions, but we will be organizing virtual trainings, targeted virtual trainings very soon. We will share the schedule with you. In terms of the upgrades, I think we are giving ourselves up to mid next month, because we do also understand there's some bit of reorganizations at the lower levels. So we're giving ourselves up to mid next month. We'll do a check-in. Meanwhile, we'll organize the trainings, the virtual trainings, and then finally we'll do a quick check-in to just see how many sites have been upgraded, how many have not, and we'd also expect that you share with us over time through the service desk in case you're experiencing any challenges. You just let us know, because we are available all the time to provide that kind of support. So I think up to this point, I really don't want to belabor a lot. We've come to the end of our webinar. I think we will be interacting more as we move forward. Allow me to appreciate and thank all the teams for finding time to attend our webinar. I know there are people who joined in late, like I was able to see so many CHRIs who joined us. We really appreciate the CASCOs who joined us. We really appreciate you taking your time, the facility teams, leadership at the county, sub-county, and even at the facility level and at the national level. We really appreciate your support, and we're looking forward to your collaboration. Kindly note that the recording of this webinar will be hosted in the KenyaEMR YouTube, which I think most of us can be able to access, and the link will also be the link to that particular recording will be shared with all of us. So up to that point, allow me to just end this particular session and say thank you very much. Feel appreciated. Have a great evening and the week ahead. Thank you very much and be blessed. Bye to everyone.